それでは定刻になりましたので、第48回の東京大学医学教育セミナーを始めたいというふうに思います。本日はですね、新しく東京大学医学教育国際協力研究センターの特任教授ですね、として着任されましたジェフリー・ウォン先生の、第1回のセミナーということになりますけれども、ちょうどですね、以前こちらの客員助教授として、おられましたですねダニエル・ウォルポー先生もちょうどその日本にお見えだということで、こちらでですね、同時にお二人にセミナーをしていただくというふうな、非常に贅沢な会になる予定です。で、今日のですねテーマに関してはエクスパティーズ、ここでは熟達者というふうに訳しておりますけれども、専門家というふうな訳になっていることも多いかと思います。ただ専門家というとスペシャリストであったり、あるいは時々はそのプロフェッショナルですね、専門職と最近訳されたりしますけど、というふうな用語とですね、ちょっとごっちゃになりやすいということで、教育学では比較的この熟達者というふうな訳が当てられていることが多いかと思います。ちょっと概念的な話も多いかということで、両方の先生方にはですね、ぜひその難しい言葉には日本語をつけてくれというふうなリクエストもあって、どれぐらいその助けになるか分かりませんけれども、そういうふうな工夫もさせていただいています。で、お一人目がですねウォルポー先生で大体45分検討、それからお二人目ウォン先生が30分検討でお話しいただくというふうな予定にしております。略歴等に関しましてはですね、皆さんのお手元に資料があるかと思いますので、そちらの方をご覧ください。So today we can enjoy the luxury of two speakers for the seminar. So the first speaker will be Dr. Daniel Wolpaw. The title will be Expertise and the Expert Learner.
Thank you. So thank you. It's a real pleasure for me to be back here in this room and see some familiar faces. It was 9 years ago, right at this time, that I arrived in Tokyo for the first time and came to the IRCME. So it's a pleasure for me to come back, have the opportunity to come back and share some thoughts with you about a subject that I've become interested in over the last few years, and that is how we think about experts and how we think about expertise, particularly when it comes to education. So I just want you to think about this. Often we're a little shorter on time today, so I'm not going to get your thoughts, but I think everyone has an idea when you say the word expert of what an expert is. And I've done this for a lot of different audiences. And mostly the things that come up are these traditional kind of thoughts about what an expert is. That it's somebody with a lot of answers. When you ask an expert a question, they tend to have the answer. And they can do it without working hard. It's effortless. They can do this without expending a lot of energy and come up with the right answer or the right approach. They tend to be very efficient. They do things better and faster than people who are not experts. There is a tendency also to, when you look closely, to when a question is asked or a problem is presented, to think about that in terms of what they know already. So to interpret this, and I know when I talk to students and residents, they know that when they approach a professor with a question, they're likely to get an answer that is related to the area that the professor feels most comfortable with. So if you ask somebody a question about something that could be related to their field, they will answer in the same language or in the same content related to their field. So this is called, in the literature about expertise, this is called routine or even crystallized expertise. Crystallized meaning it's kind of set, and that once you're an expert, you're an expert. And there's a little inflexibility. It's not the most plastic or flexible thing when you're an expert like this. You tend to look at things from a certain point of view. So I wanted to challenge you for a minute and think about this situation. This is a quote. This is actually an observation that was made of a surgeon in the operating room in a study that was done by Carol Ann Moulton, who I'll mention a few times here. She's a surgeon in Toronto. As the fellow was transecting the liver, the surgeon, recognizing unusual anatomy, said, "What the hell is that? Let's just stop and see what we're doing here." The surgeon then placed his hand on the field to prevent the fellow from operating, looked up at the ceiling for a few seconds with his eyes closed. When asked afterward, he half joked, "I'm looking at the textbook in the ceiling." So this is not the usual thing we expect of an expert. We would expect the usual expert to know exactly what to do, quickly, efficiently, and take care of it. And maybe not to even encounter a situation where he or she was not sure what was going on. We expect an expert to almost always know what's going on. So this gets us into an area that has been called adaptive expertise, which is really a different way of looking at expertise. These two authors, Bereiter and Scardamalia, who are Canadian, have written a number of things, including the textbook that they wrote in the 1990s, which is very helpful in trying to figure this out. And the main thing about this is that they talk about adaptive expertise as being progressive problem solving. So instead of having one problem and just saying, okay, we're done, there's a next question, there's a next problem. Always kind of looking for another challenge to take on. And there's this concept of adapting to new input. So if something new comes along, the adaptive expert doesn't ignore it. The adaptive expert thinks about it as a new challenge to deal with. And that involves some creativity and really some heroism. Adaptive experts are often asking questions when other people want to move on to the next subject. That's the person who can be irritating and say, wait a minute, I think there's some more questions to ask about this, and everybody else wants to move on. And when you think about important scientists in history, often they're the people saying, I want to keep asking questions, when everybody else said, no, we know the answer to that. Let's talk about something else. So there is some aspect of not being afraid to ask questions. And then there's this interesting part of this kind of an expert that doesn't ever rest. So I think the best example for me is learning to drive. I don't know how many of you have taught a teenager how to drive. It's not a fun experience. But when you're learning to drive, you have to think about everything. You have to think, now I turn on the turn indicator, now I have to look in the mirror. Everything you have to think about. Now when you're driving, you just drive. And you may be talking on your cell phone, although that's not very popular with the police in the United States these days. You may be listening to the radio or having a conversation, but you're not thinking about what you should do every minute. You've developed some form of expertise in driving, and it's unconscious. You don't think about it, you just do it. So you've created some space in your head that you could use to do something else, like have a conversation or listen to the radio. Adaptive experts are using that space to get better at what they're doing. They reinvest that space in their head, that additional brain power they invest in trying to get even better at what they're doing. So if this was a race driver, that person might be looking at all the other cars on the road and saying, how can I go a little faster, or listening to the engine and how can I get some more power out of the engine. They may be doing some additional things that make them a real expert in driving. The rest of us, we just drive. So we need to be routine experts. We need to know things. We need to work very hard to learn things. But then the question is, do we stop learning at some point, or do we continue to learn? So what the main difference is that some people get to be experts and they stop learning at some point. Or they were learning, but then they stop. And I think we've all had the experience of very senior faculty who were leaders in their field, but now whenever you ask them a question, you get the same kind of answer based on what they already know. They're not exploring new things. So routine or crystallized expertise is really a person, but adaptive expertise is a process. So you don't get to be an adaptive expert and then you're done. Okay, you don't get certain degrees and then you're done. You have to keep being an expert every day and asking questions every day. Some of you may be familiar with the Schoen work on the reflective practitioner. He talked about knowing in action and reflection in action and reflection on action. Knowing in action is really the kind of driving the car kind of thing. It's an automatic. You know how to do it and you do it. You don't have to think about it every time you do it. And experts have a lot of this knowing in action. They're very good at that. Daniel Kahneman, who's a Nobel Prize winning economist, wrote a book in the last year called Thinking Fast and Slow, which is very interesting. I don't know if it's translated into Japanese, but he talks about System 1, which is our automatic responses, and System 2, which is when we have to think about something and make an effort to think about it. And then where adaptive expertise comes in is in between these two. When do you know, like the surgeon who put his hand over the operative field and said, stop, how did he know to do that? What was going on in his head to slow down and say, stop, I need to think about this, instead of just going on? It has to do with noticing things, it has to do with asking the next question, and it has to do with slowing down, which is a concept that Caroline Moulton has put forward, which I think is very helpful. And just a few more parts of this, if we think about this as acknowledging what you don't know, identifying or admitting uncertainty or gaps in knowledge, asking questions, that all goes on between the things we do automatically without thinking and the things that we need to think about. So what does this look like? In particular, what does it look like in our learners? Which is, as teachers, that's what we want to know. How do we recognize it, and then how can we go about trying to encourage it or teach it? So I want to go through a few different things. Breiter and Scartamalia, in their book, give a really interesting example of students who are learning they're in a music class, so they're learning about music. And the teacher plays some music for them that they've never heard before. And there's some of the students who, one group of students will say, well, I don't know what that music is, but it sounds like Baroque music. So I'll just call it Baroque music and I'll move on to some other question. Next question. So they have just taken what they know and tried to adapt it to this question that was asked to them. and their learning stopped right there. And there's another group of students who might say, well, I don't know what it is, I need to do some research. I need to go to the music library and listen to some different music and see if I can figure this out. So that learner has created an opportunity to learn more things, to grow their learning. And that's an important difference, and I'm sure that you see this. We all see it in medical students, in the medical profession, where you present a case and some students will just come up with an answer and that's it. And other students are stimulated to go and do some research and think about it some more. I think there's an element of just asking questions then about this. Questioning is very important, and it may sound like this: I don't understand. The student who says, I don't understand, why do you think that? What's the evidence for that? These are all important questions. When students in the groups that I teach start asking questions like this, I know that they are thinking very hard about it, and I know this is somebody who's going to learn a lot in whatever situation you put them in. They'll ask questions like, what if? And they're asking questions that aren't, what is this? They're asking questions that go to what we call higher order learning: understanding, applying, analyzing, creating. These are good questions, and we'll talk about that a little more in a minute. The slowing down I talked about. I just wanted to say one more word about that. We looked at this diagram. So Caroline Moulton did a very interesting study in the operating room where she interviewed surgeons and then she observed them in the operating room. And we talked about stopping. The surgeon that we had the quote from before stopped the operation because he noticed there was a need to slow down and to think about what was going on. But she also noticed that there are some surgeons in some situations who will drop out of the conversation. People in the operating room, they're talking about what they did last weekend, about what happened in the last football game, a lot of conversations happening, but they drop out of that and they focus on what's going on, and they may tell other people, stop the music, turn off the music, we all need to focus here. So they haven't stopped the operation, but they remove distractions, they focus more intently, or sometimes it's just a very subtle change in how they behave. It's a great laboratory to look at the process for an expert, how they adjust, how they adapt to whatever that situation is. So I've been interested, I know that your son is very aware of this. I've been interested in this concept of Shoshin, and but this is an important part of adaptive expertise, because if you think that you know, and you go into a situation where you think you know the answer to everything, then you're not going to learn as much. So the idea of beginner's mind, of Shoshin, is very important to this whole concept of adaptive expertise. And two authors who've written in this area, Myelopoulos and Woods, describe adaptive experts as viewing themselves as accomplished novices rather than answer-filled experts, making them less concerned about maintaining the appearance of competence and more willing to recognize gaps in their knowledge and create learning opportunities to address them. You know, it's hard to underestimate how important this is. And it's interesting to hear descriptions of scientists who have won Nobel Prizes and how they're continuously asking questions and don't really care whether you think these are good questions or not. They're not afraid that you will think that they're not smart because they're asking questions. They have this beginner's mind, this Shoshin. And then there's this quality of the adaptive learner as someone who is willing to identify gaps and say, I don't know this, I need to learn about it. this is related to the other things we're talking about, but we try to have our students in our medical school do a lot of reflecting and say, this is what I'm doing well, and this is what I'm not doing well, and this is how I'm going to try to get better. Some people are better at those reflections than others. And I think you'll notice when people spend a lot of time thinking about what it is they can improve on. So I want to spend a few minutes and talk about how we then translate this. If the adaptive expert is someone who is asking questions, identifying gaps, has this beginner's mind, then how do we teach that? I mean, we're in the field of education. We want to design educational programs. There was a very important book that came out, I guess a couple years ago now, by Cook, Irby, and O'Brien called Educating Physicians. They spent a year surveying medical education in the United States for the Carnegie Foundation and wrote this book. And in the book they say, as we see it, an educational program has failed to achieve a key part of its mission if it produces physicians who perform routine work skillfully, but rarely see new possibilities or greater complexity in their daily practice. So they're asking that we do something. They spend actually a whole chapter talking about how we should be trying to promote flexibility and adaptive expertise in our medical programs. So I'm going to go through a few things, and I will repeat this slide. Basically, I'm organizing this into things that involve students, things that involve faculty, and things that involve curriculum. So I'll start with a subject which is near and dear to my heart, related to this approach to case presentations that we call SNAPs. And I don't have time to talk a lot about SNAPs today. This is something that I've worked on with my wife Terry, and she's published a number of articles about. And some of it is what students will do anyway. It's basically a student-centered approach to a case presentation. But I just want to point out that two important parts of the SNAPs presentation are the idea that the student is required to ask a question. It's not, do you have any questions? And the student says no. I know that our students are afraid to say that they have questions, because what generally happens is that then the faculty member says, that's a very interesting question. Why don't you go home and read about it, and then come tomorrow and tell me what you found out. So that's the last thing that a student wants to have to do. So they try to avoid asking questions. But in the SNAPs model, a question is required. And when you think about it, when a learner is asking a question, it means their brain is working. It means they're thinking about something. And I can tell you, if you ever have the experience of using this model, a student presents the case, they're required to talk about what they think is going on before I even ask them. And if they forget to ask me a question, I say, what is your question? And you can see them start to wake up and brain starts to move. And that question is really something usually very practical, like, I don't feel comfortable listening to the lungs. Can you help me do a better job of a heart exam or a lung exam? Or how often might you see strep throat without lymph nodes in the neck? Or something very practical that usually, as a teacher, you can answer. And there's another part of it where a student needs to select something to read about and to learn about. And this has been studied, and when students are required to use this presentation, they think of questions and they think of things to learn about. So you're kind of requiring them to develop adaptive expertise by requiring them, the students or learners, to ask questions. This has been used with residents and with medical students. We start with our medical students in their first year, which is like the third year of your medical school, but we start very early talking about this. I'm not going to go into depth about this, but SNAPS is learner-centered, helps to set the learning agenda. It gives you the opportunity also to give feedback. If a student is not asking good questions, then you can help them to ask better questions. This is something we just don't pay a lot of attention to, is how good are the questions that our learners are asking. Because not all questions are great questions. Because you don't really only want to know what the learner knows. You want to know what they need to know. And you want to know what they're going to learn when you're not asking them questions. This is what it means to be a lifelong learner. We talk about the importance of this because so little of what our learners are going to use in their professional careers are we able to teach them in medical school. They're going to need to keep learning. We all need to keep learning. New things are coming all the time. So how is that going to happen? And it happens because learners, or myself, or you, ask a question. So I just mentioned this, but I think giving feedback on questions is important. And I think not all questions are created equal. My wife and I used to argue about this. She would say any question is a good question, and I would say there are some questions that are better questions. And I think questions like, why is this happening, or how is it happening? What I love is when students work on something, study something, and then come into their group and say, you know, I read about this, but I still don't understand this. That is the best possible question that somebody could ask. If they don't work at it and they just come in asking a question, that's not as helpful. If somebody really has thought about it and then asks a question, the chances are that other learners are going to have a similar problem with their understanding and a similar question. I just repeated Bloom's taxonomy for you here, just this idea that this lower order learning with remembering, there are all these areas of understanding, application, analyzing, evaluating, creating, that are important. All these things are important, including remembering, but we're really looking for more than that when we're looking at questions from our learners. The other thing that I think we all would like our learners to be skeptical, to not accept things at face value, whatever it is, in whatever part of their life. And we'd like them to be able to look at literature or textbooks and say, well, this is good or it's not good. This is helpful for this or not helpful in other ways. We'd like them to be critical consumers. We'd like them to be able to look critically at what they're reading and interpret it in a way that is helpful to them. So we started something interesting just this last year in our medical school with our first and second year students, which for you are third and fourth year students, where we asked them to, in their cases they get, in their problem-based learning, one student every week gets an article, has to look up an article and then present it to the rest of the group. And critique this article. And we have them use this template. It's very straightforward. They need to say what their question is. Why did they look for an article? What was it in the case that made them think about what they were going to try to look for? How did they find the article? And then how did they analyze it? Was it valid? Looking at design, biases, the results, and then probably the most important step, does it help them with the case that they're trying to, this patient or the case, does it help? So apply it to what they're doing. So this is a very simple template, ask, acquire, analyze, apply. And we called it evidence-based IQ. IQ is our word for our PBL groups. So it's like evidence-based PBL. And IQ stands for inquiry groups. But we found this very, very helpful. We've been doing this over the last year, and it's really increased the awareness of our students that they need to look critically at the information that comes their way. And I think it's really important for faculty to role model this. There's no substitute for faculty to say, I don't know. There's no substitute for the faculty to say, stop, we need to think about this, and to show the learners or their colleagues that it's important to slow down and to ask those questions. This is something from the medical record at our institution. A complex patient. This patient wound up having retroperitoneal fibrosis, a very unusual problem. And the faculty member wrote in the medical record, I'm concerned about this collection of symptoms in a previously healthy man. Alternative explanation of his pain, weight loss, renal insufficiency, lower extremity edema, particularly a unifying diagnosis, are not obvious. So the faculty member is saying, I don't know what's going on. In this case, the residents were saying, I think it's peptic ulcer disease, and they were getting tests on the basis of that. But the reality is sometimes you have to say, I don't know, and you have to be willing to ask the next question. I have never heard this music before, I need to do some more research. I don't know what this disease is, I need to do some more thinking and research. And faculty need to model that for our students. And then, as faculty members, we need to encourage questions and look for questions. So I talked about that in the SNAPS presentation. SNAPS is really the student's responsibility. The 1-minute preceptor, which I'm sure you're all familiar with, where the faculty member is asking the questions. But these can be very important questions. Why do you think that? How did you come to that conclusion? I mean, I think a lot of faculty, it's hard to get them to even say, what do you think? But then there are other questions which can be very helpful to the whole educational process. How did you come to that conclusion? And even adding another, what if? What if, the temperature was higher? Or what if the hemoglobin was lower? Or just pick your what if. What if something what if the chest x-ray looked normal? It can be any of a variety of things. The important thing is the questions. We can encourage our faculty to encourage our students to use SNAPS. And I think one of the really important areas that's been ignored is the idea of training faculty to give feedback on questions. I think we just don't do enough work with trying to get our learners to ask better questions. There was a study done about 10 years ago that was never published that was very interesting on this subject and had a course in helping learners to ask better questions. And I think it's something we really need to think about. I think this is something that I've thought a lot about. When we train learners to give answers based on what they know or think they know, rather than what they need to know, then we shouldn't be surprised when we get answers in situations where we should be getting questions. So I guess I would ask you at some point, now or later, to think about this. Because our whole educational system is based on asking students to give us answers. We give them information, and then we give them tests, and we ask for answers. And lots of times, there's no real clear answer in real life. Things are not so clear. And we would like our learners, instead of giving us the best answer they can think of, we would like them to give us a question. And say, this is what I'm interested in about this. I need to read about it, and then let's talk about it some more. We need to give them an appreciation for what they need to know. I think I'm going to go through this pretty quickly. In curriculum, we're talking about small group learning, which problem-based learning we call our case inquiry groups, but where students take on the burden of figuring out what the questions are and trying to answer them. And then team-based learning, which is a different approach, but challenges learners to consider things that they may not have thought about. I'm not going to go into detail about team-based learning. There are some references that I list in the handout for team-based learning. It's an alternative approach that some curriculums are using. We use it to a certain extent. And I think the important thing is that it emphasizes the process of thinking and less what the exact right answer is. We also have this. This hangs in all our small group learning rooms in a big chart. And we refer to it. We try to get our students to think about this process of slowing down, dig deeper, the idea of calling a huddle or a timeout, reflecting and feedback. There are a lot of aspects of adaptive expertise which are in what we call team tools related to problem solving and process. So that's another way that we try to support this. And then I've become interested recently in this idea that we should be doing more with debate or argument. Jonathan Osborne wrote a couple years ago in an article in Science called Arguing to Learn that the cultivation of critical skepticism, a feature that is one of the hallmarks of the scientist, would appear to have only minimal value within science education. Yet research has demonstrated that teaching students to reason, argue, and think critically will enhance students' conceptual learning. This will only happen, however, if students are provided opportunities to engage in deliberative exploration of ideas, evidence, and argument. In short, how we know what we know, why it matters, and how it came to be. So this is really an argument for setting up our curriculum to support adaptive expertise, to support critical thinking about what it is we know and how we know it, and how we should be asking the next question. So just briefly to finish up, I wanted to try to put together a concept map for you. And I have an English version, but I'm going to use the Japanese version. So this up here is what our students know or think they know. And down here is the answer that they give, or the outcome. And when you think about it, most of our education happens right here. We try to teach them things, then we ask them questions about it, and we ask for their answers. And partly what I'm arguing, and this is really routine expertise. If you ask an expert a question, they will give you an answer, and most of the time, it will be the right answer, because they know a lot, and they are experts. They are truly people who have achieved a high level in their field. But sometimes they have to stop. They have to stop the operation. Sometimes they have to look at the textbook on the ceiling. Sometimes, and often, our students need to do that. So there's this sidebar, this alternative pathway that takes a little longer. It's not as straight as this, is what they need to know. And what you want our students to do, what you want our learners to do, is think about what it is they know and how much of that is helpful and what more do they need to know. There's some music. I know it sounds a little like this, but it's not exactly. What I have up here doesn't help me to answer. So I need to learn some more. And I call this this loop over here is the loop where adaptive expertise comes into play. And if you think about the things that I just talked about, asking questions and getting feedback on questions, snaps, problem-based learning and team-based learning, critical appraisal, setting up arguments or debate, these things all support this process of thinking about what it is you need to know, asking questions to get to what you need to know, rather than just giving an answer. And there's some very interesting educational literature that supports this idea that you need to go out here. It took me a long time to think about how to put this as a concept map and draw it this way, but I find it very helpful to think about this. This is what we're talking about here, is taking a little extra time, slowing down, thinking about, reflecting on what we need to do, especially for our learners, especially in education. And we do far too much of this. Learn this, answer this. That's mostly what we do in traditional education. We need to do more of this. So in summary, I think we talked about what expertise is and an alternative look at expertise, this idea of a progressive problem solving, of a process and not just a person as being an expert. We talked about we talked about faculty and how we can best teach and encourage the development of expertise. We talked about curriculum. So we wind up with a little bit of a toolbox for learners, the importance of question and Shoshin, SNAPs and critical appraisal, incorporating that into our curriculum. For faculty, role modeling, expecting and improving on questions. And the curriculum, putting things in the curriculum like PBL or TBL or debate, but things in the curriculum which help to support this process. So it isn't just individual, it's not just the faculty's responsibility, it's the student's responsibility and it's the school's responsibility to have our students be awake and thinking about things. It's not the subject specifically here today, but a very important concept in education now, I think around the world, is this idea of flipping the classroom. And what that means is, instead of having a classroom where you come to learn things, you learn things through podcasts, through internet, through reading, and then you come to the classroom to talk and discuss with your colleagues, with your teachers, to solve problems, to ask questions, because those are things you can't do on your own. There's so many ways to learn information now. The idea that you come to class to learn information is really going out the window. So we have to think about what we're doing in our classroom and why that's important. And it really has to do, when students are coming to ask questions and discuss and learn from each other and learn from faculty, they're really practicing adaptive expertise. So I have a fairly extensive reference list for you here. There's a lot more. And there's some references on team-based learning for those who are interested, because that's a relatively new concept. This is a statue at Hakone Open Air Museum with I happened to catch a bird up in the corner there, so it kind of like, the statue is never going to catch the bird. So to me, adaptive expertise is the art of never arriving. There's always a next step to take. You never arrive and say, okay, I'm an adaptive expert, everybody needs to view me that way, and I will die an adaptive expert. That doesn't happen. It's a process and you need to keep working on it. Okay, did you want to do questions?
それでは次ですね、ジェフリー・ウォン先生に、お話しいただきます。Next speaker will be Dr. Jeffrey Wong. The topic will be assessing the developing expertise in learners.
Thank you very much for having me here. It's my pleasure to be here for the first time. I've been here for now about a month and have been really enjoying my time at the research center here in medical education. And I was really excited to hear that Dan was going to be here. Dan is someone that I've looked up to for a lot of years, working with him in the United States, and really enjoy listening to him talk. He's spoken to you a lot about and given you a lot to think about the notion of expertise, particularly adaptive expertise. I want to shift gears a little bit in my talk and have you take a step back and think about what it is that we do as teachers when we are looking to evaluate people, evaluating learners, and what we do in teaching. And some of my examples that I'll use are more in the realm of graduate medical education, which is where I spend a lot of my time, but they're still applicable to medical students as well. So evaluating people in situations is a necessary and unavoidable aspect of life, right? And people that do evaluations well and are successful at assessing what's going on properly will be more successful. Even evaluations that may seem quite trivial or mundane can have enormous consequences on outcomes. So just to give you an example, here's something that probably most of us do every day, sometimes many times a day, without thinking about it very much. And that is walking across the street. We have to evaluate whether or not the car is really going to stop for us as we're walking across the street. And if we don't evaluate well in that situation, the outcome can be very bad. We do this a lot with not even much thought. And I would suggest that when we're teaching in medicine, a lot of times as we are evaluating our learners presenting the case to us, the information that they're giving us, we're evaluating what's going on, but we're not doing it with a lot of mindfulness. We hear the story, we try to see whether or not we can trust what they're saying. We have all the labs, the x-rays, the values that we need to be able to take care of our patient. And I'm going to suggest to you that if we can be a little bit more mindful about how we are engaging in this evaluation, we may be more successful. So that's the title of my talk, Assessing the Developing Expertise in Learners. And what I'd like to do is sort of give you some ideas on how I think being more mindful about this will make us more successful. As far as learning goals, I just have a couple of large ones. The first, I'm going to give you some of what I believe are personal observations regarding the way that we assess learners in medical education, also known as evaluation. And I hope I will give you some opportunities to stimulate some reflection on your own, perhaps thinking about how well do I do this now, and what might you be able to take from my presentation today that may help you in the future. In terms of learning objectives, I'm going to try to outline for you and develop what I think are 3 fundamental concepts that are necessary for us when we're assessing learners. I'm not going to get into any details, but I'm going to talk a little bit about the basic points of the Accreditation Council on Graduate Medical Education's new accreditation system, because it's what those of us that deal with residents in the United States are dealing with now. And this new accreditation system is based on the 6 core competencies. And there's a milestones project wherein they are trying to take levels of performance for different areas of progression through the system as part of these standards for competency, sort of the routine expertise, perhaps, that Doug was talking about. I'm hoping to go through that and then perhaps at the end show some relationships on how we can do this in a way that may promote more adaptive expertise. The structure of what we'll do here is pretty simple. I'm going to start off with talking about assessment, defining that, and sort of the educational purpose of assessment. The 3 overarching concepts I've named in a way that hopefully is a little bit unusual and will allow it to stick in your memory. The first concept is going to be called Yogi Berra. The second concept is going to be called Whitney Houston. And the third concept is the most important thing. And if you leave here remembering those 3 things, then I've been a little bit successful today. We're going to talk about the ACGME, as I mentioned, and then sort of making some ways for adaptive expertise. So, I want you to now imagine that you are an expert and you're going to teach some learners a skill. Some skill that you are very, very good at. I'm going to actually, though, since trying to make this a little bit lighter, take this outside the realm of medical education and imagine yourself that you are this expert. This is Gavin Badao. He's a PDA professional golfer. This is in honor of Kitsumura-sensei. And he's going to teach us a technique.
Today we're going to do the greenside chip shot. This shot is designed to get the ball to clear the rough when you're just on the edge of the green, to land on the green as soon as possible and roll out to the hole. You're going to use this shot if it's not possible to use your putter when you're on the edge of the green, because this grass is just too thick. A setup for this shot should put your feet together. Ball opposite the middle of the feet. Shuffle your toes slightly to the left. I want to put a little bit of extra weight onto your left side. So the weight favours the left side 60% to 40% on the right foot. Hands are in the normal position, which is opposite the inside of the left thigh. It's a little mini swing. It's almost like a putting swing. Go through the shot, you go through impact, keep the hands ahead of the club. How far you want the ball to go is dictated to by the length of swing. And how far you take the swing back should go the same distance through the shot. Now, depending on what club I use, depends on how far away the flag is. Now, if the flag is close to us, I'm going to use sand wedge or a pitching wedge. Now if it's a bit further away, I'm going to use a 9-iron or an 8-iron. And if it's further away again, I'll use a 7-iron. Same swing, just choose the club according to how far away the flag is. Let's play a shot. Feet together. Ball opposite the middle of the feet. Shuffle your toes slightly to the left. Weight favouring your left side approximately 60%. A little mini putting swing. Keep the hands forward as you go through the shot. Let's play one. Play like that. You'll be a great chipper from around the green. Today we're going to do the greenside chip shot.
Okay, so now you've done your demonstration of this skill, and now it's the learner's turn. So you're going to now be in evaluation mode, right? They're going to be up there chipping, and you're going to watch them. Now put yourself in their shoes. You've just explained to them in painstaking detail all of the mechanics they need to do. Now they're supposed to recreate that. How do you think they're feeling at this point? How do you feel when someone says, I'm going to evaluate you now? Do you kind of feel a little uneasy or maybe a little scared? Maybe sort of like this little girl here who is talking with her in front of her teachers. I thought this was going to show, but we have another one there. It says, I'm sorry, Mrs. Greer, but I can't function under this kind of scrutiny. Well, so this little girl can't function because people are looking and evaluating her. But if we fast forward the 15, 20, maybe 18 or 20 years from now, she's now a resident working with you in your program, whatever that program might happen to be. And at least in the United States, when she's working on rounds with her attending physicians on the wards or in the clinics, it would be very unusual for the attending physician to say, okay, I'm going to evaluate you now. But that is precisely what is going on. And when we listen to presentations and when we see what we're doing, we're evaluating. And then when we are taking care of patients ourselves, others are watching us and are evaluating us. It's happening constantly. We're always under scrutiny. So one of the exciting things about teaching is when you get the learner's light bulb to turn on. Watashi no musume, this is my daughter at Disney World. And the excitement of seeing the light bulb turn on is part of that evaluation. You want to see that they're achieving what's going on. And so evaluation, this is the Stanford Faculty Development Center's definition of evaluation or assessment. It's the process through which the teacher assesses the learner's knowledge, skills, and attitudes based on the criteria related to educational goals. So what we're doing was we're trying to see how well the learner has been able to achieve the goals that we have set out for them. Another way of looking at this, though, is it's an opportunity, a gift for us as teachers to know whether or not what we tried to do worked, right? Was our teaching successful in helping them to achieve their goals? If you think about what the educational purpose of assessment or evaluation might be, it's sometimes described as a triadic relationship between a teacher, a learner or a group of learners, and some information, some material, some content that is supposed to be learned. And the evaluation process are those techniques that a teacher does to try to figure out how well the learner and the content are interacting. So this is the first point that I want you to think about. I don't know how many of you know this man. This man is a picture of Yogi Berra. This is the first item that I want you to remember. Yogi Berra was a major league catcher for the New York Yankees. He was born in like the late 1920s and is still alive today. He is arguably one of the best major league catchers of all time. One of the reasons that I have Yogi Berra up here is that Yogi dropped out of school when he was in the 8th grade. And he always gave interviews to people, and he always answered questions in a way where he just fractured the English language totally. And there are these so-called yogiisms that are attributed to him, that are sayings that he said that really, you sort of understand what he was trying to say, but they really don't make sense. One of his sayings, one of his yogiisms really sticks to this first point in education, and that is, if you don't know where you're going, you might end up someplace else. And so what this is really speaking to is that we as educators need to really establish what the learning goals are. What are we trying to achieve? If we can't describe that very well, then our learners won't necessarily know what it is they're supposed to learn or how we're going to evaluate them. There's another yogiism that was also noted that helps in terms of evaluation, and that is this. You can observe a lot just by watching. What I would argue, at least in the United States, is that we perhaps don't do enough observation of our learners. Doug described a very nice situation, what they do in his school, but I would hazard the guess that most schools are much less focused in on that than his experience has been. Observing learners has a lot to do with what we do as teachers. There was an educator by the name of George Miller who has published a lot in the medical education literature, and he talked about this whole idea of observing learners in medical school. And he actually had a story that talks about if we trained piano players the same way that we trained physicians, what we would do is we would put them in a small room with a piano, have them close the door, go in and play the piano for a little while, come back out, and tell us how it sounded. And if you think about it, that's a lot of what happens, at least in the United States, with residents and with people in clinics. We send them in with the patients, they do their thing, they come back out. And I think that's kind of a crazy way to teach. So the whole idea of observing learners and making sure that we're doing that in a way that is useful and helpful for them is important. But I would suggest to you that just observation itself isn't necessarily an easy thing to do, and it's something that can be challenging. So I'm going to have you all do an exercise right now. Imagine that you are clinical teachers observing one of your learners interviewing a patient with chest pain in the emergency room. If we were doing this in the United States and you were internal medicine physicians like me, you would be using the internal medicine scale, satisfactory to superior on a scale of 1 to 9. But in any case, let's do this.
So, Mr. Hawkins, when did this chest pain start?
About 5 a.m. this morning.
Okay. Did it come on you suddenly?
Woke me up.
Oh. Does it feel like a pressure or a squeezing sensation?
Yeah, kind of like that.
Okay. Does it move around at all, like up into your shoulder or your back or your jaw?
Kind of got over here on my left side.
Okay. Does it get worse when you exert yourself?
What do you mean exert myself?
Oh, I mean like walk around or up a flight of steps or something.
Well, it got worse when I got up and went in the kitchen.
Okay. Do you have any shortness of breath with this chest pain?
No, not really.
Okay. Does it make you feel like you need to vomit?
No, not really.
Okay. Has anybody in your family ever had any heart problems?
My father had a heart attack.
Okay. Do you have high cholesterol?
Yeah, a few years ago, a doctor said I did, and he just said to watch out for my diet and to get some exercise.
Okay. Do you smoke cigarettes?
Yeah.
You take any medications?
I take HCTZ and vitamin.
Okay. That HCTZ, that's for high blood pressure, right?
Yeah.
Okay. Have you ever been hospitalized?
And the tonsils out when I was 5.
Okay. Well, I guess I've got all the information I need. I'd like to go on and examine you now.
Well, what do you think this is?
Well, so with chest pain, we always worry about the heart, but I'm going to have to collect some more information before I can know for sure what's going on.
Okay, so now you saw him. How did he do?
I gave him a 3.
A 3.
Yeah.
Okay. Anyone else? A 4? 4. Yes, sir.
2.
A 2. So you guys are all clustering pretty close. Well, let me ask you this. Would your evaluation change if you knew he was a 5th-year medical student? This is the first patient he'd seen. Would your evaluation change if he were a 2nd-year resident about to finish? Would your evaluation change if the only thing you were trying to do is figure out, does he know all of the standard questions to ask about chest pain? Would your evaluation change if you had just spoken with him about the importance of asking open-ended questions? So the point here is that what you are looking for makes a huge difference in how you're going to evaluate the performance. And what ends up happening, and there's been studies that have been going on, one of our colleagues, Eric Holmboe, at the American Board of Internal Medicine has done a ton of work looking at, these are standardized residents and standardized patients, and they have teachers evaluating the interaction. And the variety of scores is very wide unless you take the time to figure out what is it exactly we're trying to evaluate. So that's the sort of the take-home message there. So this is the second point. This is Whitney Houston. Most of you may know Whitney Houston. She was a recording artist, she was a model. I think the Guinness Book of World Records a couple years ago said that she was the most decorated and celebrated female act of all time. Of course, she had a tumultuous career and an untimely death earlier this year. But the second thing that I really want you to think about in terms of evaluation can be remembered by Whitney Houston, and it was her first hit song, and it was, "How Will I Know?" What I mean by that is that when we are thinking about our learners, how will we know whether or not they've achieved the goals that we've set for them? The more explicit and precise we can be about that level of accomplishment, the better that the evaluation will be for them. Now, George Miller, you probably know this quite well, he was one that took this "how will I know" theme and really tried to create a simple model of competence, talking about a learning pyramid, where the first level knows talks about merely knowledge, the sort of the foundation that students will use to build up. Once they know what's going on, then you have to learn how to knows how to be able to apply that knowledge to figure out things. Showing how gets to a higher level where now you're taking that knowledge, you're knowing how to use it, and you're going to be able to demonstrate that in the care of patients. And then the last is does. One of the problems that have been talked about with this whole scheme with Miller in terms of education is that as we are evaluating this going on, we still don't really know if the does, that is watching students and learners do things under our scrutiny, is really going to translate to when they are on their own out into the field without us being around. If we change this model and sort of expand it into a prism, looking at knowledge, skills, and attitudes and sort of the development of professionalism in students and learners, we can look at ways that we traditionally in medical schools and residencies try to assess these different levels. Oftentimes, multiple choice questions are used to assess the knows part, and at least in our medical school, the first 2 years in basic science training is really sort of focused on, do the students know these facts? Sometimes well-written multiple choice questions can get to the next level of knowing how. When you get to the knowing how and showing how, now you're getting into the level of OSCEs and simulations where you're asking students again to be sort of hands-on, showing me how you can do this. The last one, does, becomes even more difficult. In residency, we try to do that through direct observation and watching them working with patients on the wards and in the clinics. There's another model that some of you may know about by the brothers Dreyfus. This is actually developed when they were working with the Air Force at UC Berkeley. And it's a model talking about a progression from novice to expert, sort of like what Doug had talked about a little bit here, and going through 5 different stages. The argument is that at each of these stages, from novice, advanced beginner, competent, proficient, and expert, in this model, you have to think about different teaching and different evaluation strategies excuse me, that would be appropriate for each of those levels. One of the arguments against this model is that the way that it was initially talked about, they talked about expertise as sort of being a destination, a place that anyone would get to if you went through all the normal steps, rather than a process like Doug was talking about. I want to talk a little bit about the Accreditation Council on Graduate Medical Education, because when we talk about these different levels of expertise in our residency training, they really are tying this into this next accreditation system. The aims of this system is to enhance the ability of peer review for the 21st century, to sort of accelerate the ACAG's movement towards accreditation on the basis of educational outcomes as sort of defined by what our learners can do, and try to reduce the burden associated with the present approach of accreditation. And for those of you that are not familiar, these are the 6 core competencies defined by the ACGME: medical knowledge, patient care, systems-based practice, practice-based learning and improvement, professionalism, interpersonal and communication skills. They have these educational milestones that have now come up. And these milestones are supposed to be meaningful markers of progression towards the end, providing structure for organizing teaching and training, and thus evaluation. And there are defined levels of performance at the level first of a typical graduating medical student, at an early resident level, experienced resident level, graduating resident, and then an advanced specialist resident. And the idea is with these milestones is that you should have defined at each level what you would expect a successful person to be able to accomplish. Within these milestones are what are called entrustable professional activities. I put that in quote because even in English, entrustable is not really a word. But they've called them entrustable professional activities, or EPAs, and the idea is that these activities are supposed to reflect those concrete, critical clinical activities that together constitute what it means to be a physician or in the profession. And successful performance of these EPAs might infer competence across several of the 6 core competencies. But one of the exciting things is if they can pull this off is that the outcome of training, whether or not someone has completed their residency successfully or not, is going to be based more upon whether or not they've achieved these EPAs and the milestones, rather than they've been in residency for 3 years or 6 years or whatever we presently do now. And that's sort of where the graduate medical education program is moving toward. So this is the third aspect that I want you to think about. And I want you to think about back to your own training and what you've been doing since then, all of your lives as a professional. If someone came up to you and said, what's the most important thing you learned how to do? How would you respond? Well, reflect on that for a minute, because I will tell you that I believe the most important thing that we can learn to do as physicians, the most important skill, is to be able to learn the ability to accurately and honestly self-assess our own abilities. And I think this ties in a lot to what Doug was talking about with adaptive expertise. The adaptive expert is always looking at what's going on and reassessing his or her own knowledge and abilities and skills given the circumstance. As a teacher, we can promote self-evaluation and this reflection piece in our learners by using questions that are sort of called double you questions, or you-your questions, such as, how do you think you did? Do you think you have enough information to make this management decision? Or how comfortable are you with your plans in treating this patient? Those questions can really challenge our learners when they're about to go off and do something to perhaps slow down and reflect upon what it is that they're doing and how strongly they feel about what they're going to do. Those self-evaluations questions can be helpful. And what maybe we're doing with adaptive expertise is perhaps we're trying to teach wisdom. Doug actually shared this slide with me earlier, and I thought it was such a great slide that I stuck it in my presentation. But some of what we do is experiential learning is sort of good judgment comes from experience, and experience comes from bad judgment. And perhaps if we can get people to think and self-assess, they don't have to go through that loop of having bad experiences in order to gain judgment and experience. The whole idea of the teacher as a coach, using role modeling, asking the important questions as Doug was talking about, providing feedback to the learners, creating challenging learning opportunities for them, pushing them, keeping them intellectually curious, and providing them new and alternative perspectives that they may not have thought about before is all important. And then this reflective dialogue, thinking about alternatives, practice making sense out of uncertainty that is always going on in medical education. So this is a picture of the luxury cruise liner Costa Concordia. And the point that I wanted to make with this picture is that self-assessment and figuring out whether we have what we're doing is safe or not safe is not just in medicine, right? You have to wonder how the captain of the ship, look how close it is. I mean, what was he thinking? What sort of self-evaluation strategies was he using to figure out what he was doing was safe or not safe? if we use this analogy for our learners, what are our learners going to do when they're out on their own? Are they going to be able to assess whether or not what they're doing for their patients is safe? I think the analogy of this may also be tied into what someone has told me is the parable of the white belt. You probably all know this, but I'll relate it for you anyway. The white belt is the idea is that in martial arts in Japanese, as I understand it, that you're only used one obi. And you use that throughout your entire lifetime as you are learning your skill in the martial arts. And when you start off with a white belt, where you have no knowledge, you have no expertise, you have no right or wrong. And as you start to learn, the belt gets stained. First it turns green with grass stains. And as you practice and work more, it becomes stained brown with dirt. And as you do more and more work, it then becomes black. And at least in many places, oftentimes in the United States, black is considered mastery, and that's where you've made it. But the parable actually tells us that this is only the middle of the journey. Because at this point, the person has lots of skills, but not much wisdom on how to use those skills. And so as the person with the black belt ages, the belt itself becomes a little more frayed, and they learn more about the knowledge and the wisdom to use those skills wisely, until the belt actually has now become white again. And the person has gained the wisdom and the knowledge to do what they need to do, but not to be dangerous about it. And I think that analogy helps us when we think about our learners. So in conclusion, I'd like you to remember the three concepts. Yogi Berra, we need to establish learning goals. The second, Whitney Houston, how will I know? What will success look like? And then lastly, what is the most important thing? I believe it is to be able to foster accurate self-assessment, or perhaps in the words of Dan, to be adaptive expertise, to slow down, to think about what we're doing and try to encourage that in our learners. So let's go back just to close up to that original procedure that I had you think about. Remember what we talked about, the green side chip? You all have that in your mind. Okay. So now we are faced with a different green side chip. Only this one is quite a bit different than the first one. Here, the ball is way down in really deep rough. Here, the green is sloping away from us. It is incredibly fast. And if you hit the ball just like Gavin told us to the first time, and we learned that very well, it's going to roll right off into the water. So here, you've got what you might argue is the penultimate adaptive expert in figuring out what am I going to do to be successful in this new novel situation. Let's watch and see what happens.
You see from this position today, Gary, I'm sure you've seen a few that have been over the green and rough.
There's three places. First of all, we had 10 guys hit the green. The proximity of the hole on the 16th hole today, they average 40 feet if they hit the green. And everybody's going to right bunker to the player's right. That's been the easiest. That's been the easiest bunker shot. They can get that up and down the back one over the flag, not so much. Right here, this Peter Costas, you look at this line, look at this shot. He's got a dead vertical, he's got a ridge. Yeah, he's got Jarvis just barely over the low grass, not even over the green there. But it's a downhill bounce from there, so he's going to have to go vertical with a super high loft and just take his chances. But I say anything inside 6 feet will be a wonderful shot. Yes.
That still amazes me every time I watch it. So I guess the bottom line would be that if you can get all of your learners to be that good an adaptive expert when they come up to novel situations like that, you're probably doing quite well. In closing, I'd leave you with one more yogiism, and that is, It ain't over until it's over, and now it's over. Thank you for your attention.
Thank you very much.